to this good work that you've done.
Two more questions?
Yes.
One more, then Arif.
Thank you. My name is Monica Ogutu from KMET Kisumu, coming all the way to hear about this great work. My question is on data, and I would like just to hear from you how this is mainstreamed into the DHIS dashboard and how the counties are using this data now to inform their decisions.
Thank you. We are in constant touch with Richard and the team at Triggerize, but the presentation sparked off a couple of questions that I couldn't resist asking. So one was around his point about working with a number of community-based organizations. And I was curious about the dynamics between that and the actual private facilities that were providing the service. So the CSO/private provider dynamics on the ground. Number two, the impact therefore on the government facilities on the ground as these private providers found increased demand presumably as this program grew. And thirdly, the feedback from the girls. I mean, how critical was that in assessing eventually performance and payment on performance? Was that core to that mechanism of assessing performance, or were there other ways that we were able to assess performance before payment? Thanks.
Thank you. I will just go to Richard because Hera is online.
Great. Let me quickly ask. Thank you very much for your question around literacy. I think that was an important part of this program. When we designed this program at the beginning, we undertook user-centered design work. And part of that user-centered design work, one of the first things that we identified was literacy. What is the literacy of 15 to 19-year-old girls? And the surprising part of our data was that a 15-year-old young Kenyan girls, the majority of them in the informal settlements in slums that we report, they've got a reading age of 11. So essentially what we tried to do was to structure the IEC materials that we developed, the communication that the CBOs were delivering to these adolescents based on that particular reading age. So that was the first part in terms of the design. The second issue was around comfort. What language do they use? How do they use this particular language? And we found in all of these 16 counties that young people have different languages that they use. It's sometimes a mix of Swahili and their local language, sometimes a mixture of English and the local language, English and Swahili, and so forth. And essentially what we had to do was we specifically designed the materials on each county based on what were the prevalent and the most comfortable ways that young people expressed and used themselves in terms of the terms that we were engaging them with on this particular program. Monica, I think you asked the question around the dashboard and mainstreaming of it. We have a real-time dashboard. That dashboard we've integrated into KDHS. So essentially all of that data on our dashboard goes into KDHS. The interesting thing on this program is that we not only work with private facilities, but we also work with pharmacies. And the government for a long time, as one DG can attest, has been really keen on trying to pick up data from pharmacies. What do pharmacies sell? What is the experience of users within pharmacies? And essentially that was data that was separate. But what we did as a result of that work was to ensure that all of the facilities on our platform were registered. We got them registered onto DHS, and they will be able to report. And they're actually using government registers. So essentially, these are the registers that we created. We're using the basic form 512, 702 that the government uses, and that made the integration and mainstreaming into government databases and visualization systems very, very easy. And what that allowed the government and the county governments in particular to begin to understand is what was the contribution of the private sector to the national response toward adolescent sexual and reproductive health. And we were piggybacking, because again, we never do stuff independently. We were piggybacking on the great work already that had been done by our colleagues at JPAGO in terms of the city's program that they've been implementing. And that enabled the use of the data. And we would have every quarter discussions with the county. We agree with the counties based on the data, what needs to be addressed, what needs to be identified, if it was a training issue. And because we work with the counties directly, for instance, around joint support and supervision, the county would then come in and provide those particular facilities with the joint supervision support that was required to ensure that quality was always addressed, to ensure that the data was accurate and that they were able to begin to use it. And then finally, to that last question that Arif has asked around dynamics. Essentially, because these community organizations work in the communities, the private facilities, the pharmacies, they're all actors that they're already familiar with. And essentially, the design and implementation arrangements were really about making sure that they were introduced to these facilities, relationships was created, rapport was built, and then every quarter that these two parties interacted with each other regularly to begin to understand the issues on both sides. One, in terms of their particular feedback, in terms of the experiences that they got from young girls and young women, in terms of the services that they'd actually received, and then two, in terms of community outreach. So that people understood that yes, in this particular community, this is where young people can actually go and take up a service. Your second question, Arif, was around feedback and the importance of feedback in terms of structuring the payments. Essentially, it was not built into the contract, but as I said earlier when I was talking about some of the key success factors, what we did was we built that into the design of the program. So for instance, our providers, whether they were providing quality assurance support or whether or not they were actually delivering the service themselves, they had inbuilt incentivization around quality. So if they did not, so we withheld some money, some of those payments to ensure that they met quality standards for the girls, based on the feedback that had been provided by the girls themselves. So that was important in terms of one, building voice for young girls, and secondly, in terms of accountability for those providers for the services that they provided to young women and girls, because essentially they tend to be very asymmetrical. Already, not a medical doctor. By the time I'm already going into a clinic, I have a particular respect, in terms of opportunities to voice any particular concerns that I might have, for instance, with that particular clinician. So what the ratings enabled us to do was to provide young women and girls with that voice, and then to then hold providers accountable for the provision of services to them.
Thank you very much for those comprehensive responses. So because of time, move on to the next presentation, which will be done by our third-party monitor, HERA. And this study was done in collaboration with ICRH Kenya. And the presentation will be done by Dr. Joseph Dekosas. Welcome, Joseph.
Thank you very much, and thank you very much, most of all, for the honor to be present at this meeting with the Minister of Health and the Director General of the Kenya, with the UN representatives, FCDO, and all the partners in the project. HERA and ICRH Kenya had the task to provide third-party monitoring for this the project of 18 months. I will maybe shorten my presentation as I go along to just focus on one part of this monitoring assignment, which is the service. This is the team. I will not introduce them all. Some of them I think are present in the room. I just want to point out that maybe highlight Gerald Kitinji, who really did most of, practically all the footwork, supervised all the footwork in Kenya and really did a wonderful job in managing all the data collection and analysis. Okay, can we have the next slide? I can't control the slides, so you will have to control them and give me the next slide. Hello? Can I have the next slide, please? Okay, thank you very much. So this is the overall assignment of the third-party monitoring. And basically we were asked to identify or verify payment metrics for the development impact. These were service uptake, cost effectiveness, couple years of protection, unintended pregnancies averted, and the adolescent modern contraceptive rate, change in the adolescent contraceptive prevalence rate. Now, as I said, I think the interest of this meeting is primarily in this last indicator, which was collected through 2 surveys. So can we move forward to slide number 6 if it's possible, and then skip the other presentation. Can we move to slide 6, please? Can we please move forward on the slides? Or would you like me to share my screen? That would make it easy. Somebody who must be in control of the slides. So whoever it is, could I? Okay, we are at slide 6. So this is basically the verification of the increase in the contraceptive prevalence rate. Obviously, this can only be done through surveys. The targets we were initially informed was that the project would result in a 3.6% increase in adolescent MCPR over the 18-month areas in DIP project areas. The target population, we had several discussions about this. The choices are to do this survey among currently sexually active adolescents, usually defined as having had sexual intercourse within the last month, or ever sexually active adolescents, of course, this was a negotiated agreement that we settled on ever sexually active adolescent girls. It had to do with budgetary implications. It also had some other technical arguments which I don't want to further elaborate here. We had 2 survey options. The initial organization which was contracted, designed and did, proposed that we should use a quasi-experimental matching survey, which means to compare the contraceptive prevalence rate. My slides have disappeared. Is that normal? Hello? Where are my slides? Can you see slides in the audience there?
Joseph,
Yes?
I think we'll ask you to share because there is a weak internet in the room.
Okay, I will share my slides. Can you see the slides now?
We are trying to project in the room, but yes, online we can see.
Okay. So let me, should I wait until you finish your, solve your projection, or should I?
Just a minute. Yes, we're on slide number 6.
Okay, thanks. Basically, the choice was to use this matching survey design. The obvious advantage of it is that with this you can actually make some inference on an attribution of the project to this change. Disadvantages are the high costs that were estimated at $646,000 by the ID Insights, the agency that was tasked for it. It was also, we looked at how we would identify suitable matches to these deep project sites. And we really found it very difficult to identify urban, peri-urban areas that had not been targeted by trigger eyes, that had a similar profile in terms of adolescent pregnancy, and that could be circumscribed as a suitable match site. We actually could not identify it. And then the third issue is the ethics. The ethics of collecting match data among populations, among girls who are not in any way benefiting from the intervention. Basically, it's the principle of beneficence that could not be ensured through this design. We therefore opted for a pre-post intervention survey, which sort of assumes that the counterfactual is the adolescents in each round, minimal increase of 3.4%. Possibility that we could survey approximately 5,000 adolescents. So then, we had to go about to identify project intervention areas and, what are intervention areas and how to draw a representative sample from these areas. The DIPCAR project targeted urban and peri-urban locations with high adolescent birth rates and partners with pharmacies and private clinics. Pharmacies and private clinics are not planned to provide coverage in administrative areas in a ward or a sub-county. They are located wherever there is business. So the delay of the baseline study, which because of this long delay because of the discussions, actually provided an opportunity because it allowed us to identify where the project was active. We therefore purposely selected facilities in each county that had provided most of the services over these first 8 to 9 months of the project. Initially there were 41 facilities after we removed Ruas and Kishu because in the analysis, because Tigger stopped programming there, 39 facilities remained, which means we had 39 areas around these facilities where we could conduct the surveys. We then asked the Kenya Bureau of Statistics to draw enumeration areas within a 5-kilometer radius around these facilities. And when we did that, we found that there were another 7 facilities that were within these, the pharmacies or clinics that were within these 5-kilometer radius locations. So it came up to a total of 46 pharmacies and private health clinics. About 20% of those who were partnering with Trigger Eyes, but they had provided 49% of all services, half of all services. Based on the latest census data by KNBS, they estimated there would be 38,000 households within these enumeration areas. We then looked to see how can we get a sample of 5,000 adolescents in these 38,000 households, and we realized that we would need to actually identify and survey all girls in these areas in order to reach that sample size. Considering that not all households had adolescent girls, and considering that were not willing to talk about their sexual behavior, or their parents did not allow them to talk about their sexual behavior. And you know, considering that taking this into consideration, we said, you know, we can't sample within those clusters. We take all of them, basically 100% sample. So then we conducted the baseline surveys in June 2021. This was 10 months after the start of the project. We received the go-ahead in March. We had to get ethical approval. We had to get approval of the counties. It takes time. We had to train the enumerators. So June 2021 was the earliest we could do. The process was the same for both surveys. There was first a round of household listing, identifying households where adolescent girls who had ever sexually been active were present, and they and their parents agreed to be interviewed. The second round was then conducting the interviews. They were of course, in an environment that was fully confidential, and after obtaining written consent from parents, and or if they were over 18 or emancipated minors, from the adolescents themselves, of course, an assent of all adolescents as well. The baseline survey found that there was a contraceptive prevalence of 28.9% in this population. Our initial report reported a slightly higher one, but there were some adjustments that had to be merged the baseline at the end. There were constraints in the baseline support. COVID-19 restrictions were in place,